And SIBO breath testing, commonly deployed, a validated test. And this is just to show you a few of the data points regarding its validation. 2022 meta-analysis. And what you see here is the SIBO positive rate was 49% with lactulose and 19% with glucose. So about 50% of patients were positive for SIBO who had IBS symptoms using lactulose for the SIBO test, and 19 with glucose. Keep this in mind as we look at this next study. This next study found SIBO breath testing prevalence was 35% versus 29% in healthy controls. So they're not delineating between glucose and lactulose, but what they are saying is that those who had IBS, 35% were positive for SIBO, but 29% of healthy controls were positive. And then compare this. So it gives you some delineation, but it's not a super successful discriminator. And then this is what I want to call your attention to. Culture-based studies, where they take a sample from the small intestine, albeit perhaps imperfect, yielded a SIBO prevalence of 13% in IBS patients and 5% in healthy controls. Now, I'm not advocating for routine use of jejunal aspirate testing. It's not practical. The point I'm trying to make is when using this methodology that's supposed to be more accurate, it's contestable, but supposed to be more accurate, you're seeing a much closer proximity between the SIBO sampling directly from the intestines as compared to the glucose, right? Remember, 19% from the glucose here, which is much closer to the direct sampling of 13%. So I just want to point that out. It's one support for glucose testing. I think you can make SIBO testing work with either reagent, but just wanted to tie that together for you. And then one more study just validating or showing you the evidence that validates the use of SIBO breath testing. More than 1/3 of IBS patients tested positive for SIBO, and the odds of SIBO in IBS were increased nearly 5-fold. So there are data to support the use of a SIBO test. And final point here from the North American consensus, quoting, BT or breath testing is a useful, inexpensive, simple, and safe diagnostic test in the evaluation of common gastroenterology problems. However, the pitfalls that I want to make you aware of: reading the tests incorrectly. I think most people who are paying attention to the SIBO literature know that we want to cut off the time interval to 90 to 100 minutes. Early in the days of SIBO, one may have looked at the time point of 120 minutes, 140 minutes, 160 minutes, where a rise should naturally normally occur, and could have incorrectly said, there's a rise, you have SIBO. So we want to be careful not to commit that mistake. Additionally, focusing on treating the test results and not the symptoms. And this is where opinions do differ. One camp has a very algorithmic approach wherein you treat, you retest, and you keep treating until the test is normal. And the problem with this is some patients will have a normal test and still have symptoms. What do? Or some patients will see no improvement in their SIBO lab values with the treatment that's recommended in this algorithm, which is rifaximin and or neomycin. So what ends up happening in a lot of these cases, albeit a well-intentioned algorithm, is you focus on treating the tests and not treating the person. And again, why this is so limiting is there can be much more than SIBO occurring in the GI. As one example, we know that CFO, small intestinal fungal overgrowth, can and does occur, but we are extremely limited in our ability to test for that. So what could happen is someone, theoretically here, they have both SIBO and CFO, but they don't know they have CFO. They're treated with antibiotics time and time and time again, according to the algorithm, yet their symptoms don't improve and or their SIBO test doesn't improve. But they're never given an antifungal because there's not lab evidence to support CFO. And this is where, in the area of functional GI care, it's really best to treat the person's symptoms because we have great data for treatment of symptoms, and treating the tests tends to be much more limiting. And this also ties in with the obvious question, does SIBO testing improve SIBO treatment? And I would argue for the most part, no. Now you could counter argue that, well, if we know if you have hydrogen as compared to methane SIBO, then we could give you either rifaximin or rifaximin plus neomycin. But the difference in success rate between these two groups isn't huge. And also remember, it's not all about just treating the lab finding. You could, instead of kind of doubling down on antibiotic therapy, listen to the patient and tend to their diet, consider the integration of probiotics or other agents that help with motility or at least regularity, like magnesium. And these can also have a favorable impact on methane, because remember, methane overgrowth kind of occurs in this chicken or egg or intestinal methanogen overgrowth, as it's now being termed IMO. It has a chicken or the egg in terms of, we know that slow motility can cause high methane, but we also know high methane can cause slow motility. So an intervention that improves constipation or improves regularity can also resolve methane. And this is one of the reasons why being able to say, well, rifaximin versus rifaximin plus neomycin has been documented to lead to an improvement over just rifaximin alone, but it's not huge. So I'm not sure if you can say, well, you must have a SIBO breath test, because there are so many other supports that one could use just knowing that you're constipated that would help the methane, that does not require the SIBO methane results in order to do.